A 40-year-old woman had diabetes for 20 years. On her annual ophthalmic visit, hard exudates were noted together with retinal edema adjacent to the left macula. Her vision was 6/6 in the right eye and 6/9 in the left eye. Laser treatment was recommended. Now, in regards to this is a case of non-proliferative diabetic retinopathy, NDPR. Non-proliferative diabetic, or non-proliferative, let's say non-proliferative diabetic retinopathy, NPDR. Now, we can say this is NPDR because we have a diabetic patient. We have a diabetic patient for a long time and he's complaining of eye problems. So you think of the complications of diabetes. And in that case, when you take the fundus examination and the signs that, or the symptoms that the patient complains of, which is, in summary, chronic painless visual loss in one eye or both, actually typically it's both eyes, then in that case, with the fundus examination, you can determine this diabetic retinopathy, but be more specific. We'll say this is non-proliferative diabetic retinopathy. There's no signs of macular edema or neovascularization, but there is presence of exudate, there's presence of small hemorrhage, localized hemorrhage. They're not new vessels, but there's localized hemorrhage and exudates in regards to the rupture of microaneurysms. So we're going to say this is definitely non-proliferative diabetic retinopathy. And from the fundoscopic examination, as well as the symptoms that the patient complained of, we can say that. Of course, there's differential diagnosis for this case. It could be any other cause of chronic painless visual loss. For example, cataract, chronic glaucoma, for example, refractory error. If it's an elderly patient, it could be a case of macular degeneration, for example. And a young patient could be retinitis pigmentosa. But of course, the one way to really specify this diabetic retinopathy is through investigation. So in investigation, you'll do full eye examination. And when I always say full eye examination, I mean everything in the eye. Check the pupil, check the motility, check the visual acuity, check the visual field. But in a case of a retinal disease, you'll especially focus in fundoscopic examination, retinal examination, and you'll do other investigation that an ophthalmologist would do, such as OCT, ocular coherent tomography. This will give me a cross-sectional view of the retina for any macular edema, fluorescent angiogram, again, vascular disease, as well as systemic examination. If I'm suspecting diabetes is the cause, I need to check up on the diabetes. Maybe his diabetes is undiagnosed, or he has diabetes but it's uncontrolled, so I need to check up on systemic examination. I look at the blood glucose profile, lipid profile, echo, and so forth. So ophthalmic and systemic examination. And if we suspect then this is diabetic retinopathy, of course the treatment is number one, you have to treat the diabetes. This is caused by hyperglycemia affecting the vessels of the retina. And we'll explain shortly. But this is affecting the vessels of the retina by hyperglycemia. So you have to control the diabetes and the risk factors associated with it. High fat, cholesterol, all that stuff, hypertension, all that stuff. That's the number one first line of treatment. If there's a complication, if you have a case of diabetic retinopathy true and true, then along with that, we'll do the following treatment. It involves laser. Most cases, you just require laser and some injections if need be. We'll talk about that shortly. But before we continue, let's just summarize, let's just revise together what we mean by diabetic retinopathy. So typically, in a patient who's type 1, let's say he's type 1 diabetes, insulin dependent, or let's say type 2, for instance. Type 1 and type 2 individuals, they need to see an ophthalmologist. The only difference is the timing. For example, type 1, once they're diagnosed with type 1 diabetes, that patient should see an ophthalmologist from within 5 years. So once he's diagnosed, he can see him 5 years later. And then from that point on, every year, he needs to do an ophthalmic follow-up with the doctor. So the type 1 diabetes will have 5 years. They have to do a checkup afterwards. Meanwhile, type 2 individuals, no. Once they're diagnosed with type 2 diabetes, they have to see the ophthalmologist immediately. Now. They need to see them now. Because they might have been asymptomatic this whole time. Well, type 1, in the meantime, would be a little bit more obvious symptom-wise, signs-wise. So type 1 diabetes, they need to see an ophthalmologist 5 years from their diagnosis. But type 2, they need to see them now. Regardless, they have to do a follow-up with the ophthalmologist every now and then, so they can prevent the complication, one of the complications of diabetes, which is diabetes retinopathy. And what happens with constant high levels of blood glucose levels, they will affect the blood levels of the retina. So this hyperglycemia will damage specifically the capillaries of the retina. So we can imagine this is a capillary, and the capillary consists of endothelial cells like these ones. And outside of these endothelial cells are supporting cells known as parasites. Let's say this is a parasite around them. You see, with chronic hyperglycemia, this will damage the parasite and decrease their number, and this will also damage the endothelium of the capillaries in the retina. And if there's damage, of course, this will lead to inflammation. And if there's inflammation, and of course, if there's no capillaries being worked, inflammation comes with ischemia. Ischemia, inflammation correlate with one another. And of course, all of that will lead to what? It will lead to dilation of these capillaries. They will form what is known as a microaneurysm, and eventually this microaneurysm can rupture, or they can leak out, at the very least, exudate or edema. So typically, the first sign of diabetic retinopathy on fundoscopic examination is microaneurysm. That is the first sign. Some of these microaneurysm might rupture, they might give you little bits of hemorrhage. There's no neovascularization at this stage, but there is a bit of hemorrhage and a bit of exudates leaking out. They call this non-proliferative diabetic retinopathy. This is the first stage of diabetic retinopathy, okay? And this is what's happening in diabetic retinopathy. And then if you're neglecting, then it will progress to the next stage. So after non-proliferative, you have pre-proliferative. Of course, when we go to the proliferative stage, there'll be new vascularization. Basically, it's going to be growth of new abnormal blood vessels that easily break, and these are induced by vascular endothelial growth factors that are being released. But in this stage, pre-proliferative, they haven't been released yet. However, there's starting to be signs of more hemorrhage, more exudates leaking out from macroaneurysms, and there tend to be venous looping. Some of the retinal veins, they tend to loop around. So that's another non-specific sign in pre-proliferative. However, the most important part is the proliferative diabetic retinopathy. Here at this stage, from the name, there's going to be new vascularization. So there's going to be new vascularization. It's going to be very obvious. There's going to be, on top of that, all the other symptoms I mentioned before: hemorrhage, exudates, growth of new abnormal blood vessels, and it's from here that it's going to be a very, very big problem, because a lot of complications going to come from proliferative diabetic retinopathy. Like, for example, this bad boy right here, you might get new vascular glaucoma from the new vascularization and rupture of these blood vessels. So you might have new vascular glaucoma, for example. You might have new vascularization in the iris, so you call that rubeosus iritis, all right? For example, you could have tractional retinal detachment from previous videos, so you might have retinal detachment as well. So if you manage to see, there's a lot of complications. Like here, another one, vitreous hemorrhage. There can be vitreous hemorrhage. These are all complications that can occur with proliferative diabetic retinopathy. And if we progress even further, then these hemorrhages and specifically edema will accumulate in the macula. They call this diabetic maculopathy. That's the final stage, where they'll be characterized by macular edema. Of course, they tend to subdivide this maculopathy into ischemic and edematous type. Typically, they mean the edematous type, where there's presence of macular edema. And if there's presence of macular edema, there's a very, very high, if not guaranteed chance, there will be loss of central vision, because the macula is the place where central vision is located at, essentially, okay? So that's maculopathy. So the idea with the ophthalmologist, he wants to treat first of all, the ophthalmologist wants to prevent all of this. But if a patient has diabetic retinopathy diagnosed, then we need to treat the cause. However, before we start, we need to mention that we're going to do here, what the ophthalmologist is going to do here, he's going to go by laser therapy. Let's say we have non-proliferative diabetic retinopathy. Let's say we have macroaneurysms, and there's hemorrhage and exudates in some certain areas, here, 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 and here. What am I going to do? I'm going to do laser for this patient. I'm going to do laser for this case in general, in non-proliferative diabetic retinopathy. I'm going to do here basically laser. I'm going to do argon laser grid pattern, okay? Grid pattern. Basically, I'm going to laser parts of the retina that has hemorrhage and exudates, okay, in a focal manner, in a focal area. I'm going to laser it and I'm going to burn it so I can prevent further bleeding and hemorrhage and further progression to the next stage. So I'm going to do argon laser grid pattern, okay? So you call it argon laser photocoagulation or grid pattern. However, if I have proliferative diabetic retinopathy, I'll do the same laser, but this time in proliferative diabetic retinopathy, I will do PRP. I'll do the same laser, but it will be pan-retinal pattern. meaning I will do this laser throughout the retina, across the retina. I will do this laser across the retina, burning it, because there's neovascularization and I want to burn as much as possible to prevent loss of that central vision, prevent that macular edema from occurring. Okay, so that's what I'm going to do. I'm going to do the laser, and if it's not working, I will still do it. If these lasers are ineffective, I'll still do it, but I will still include injection inside the eye. I can do intravitreal injection, let's say IVR, intravitreal injection meaning injection inside the vitreous humor inside the eye of, let's say, steroids or AVEGF. I can do antivascular endothelial growth factors. I can give it inside the eye to prevent growth of abnormal blood vessels, because these vascular endothelial growth factors, they're the ones that promote neovascularization. And why are they being produced? Why are these vascular endothelial growth factors producing neovascularization? They're produced because there's ischemia, and this one is doing it as compensation. But we want to prevent that because it will lead to more complications. So I can add intravitreal injection of S, meaning steroids, especially in cases of macular edema, or I can add antivascular endothelial growth factors along with the surgery. This will not be replacement. This will be on top of the surgery. I mean, on top of the laser. Sorry, on top of the laser. But let's say the laser, and let's say we tried the laser, okay, and we tried doing intravitreal injection along with it of steroids or antivascular endothelial growth factors. Then what's the next step? Surgery. In that case, I'll have to do surgery for the eye as last resort, okay? But remember, the first line treatment we have to think of, before we do any of this, we have to control the diabetes. The problem with all this is from hyperglycemia. So we have to control the diabetes and the risk factors. So typically the ophthalmologist let the internal medicine doctor take care of that. Well, the ophthalmologist will take care of the other problems with the laser therapy and whatnot, okay? So this is diabetic retinopathy. This is quite important, and that's pretty much it. Thank you.